Hello, my good friends. We are here now today probably dealing with one of the most important webinars that we will do during this year, because we will talk about endotyping chronic urticaria and where we stand. Next, please. We have in the panel a very good speakers and scientists. We have Professor Emek Kocatürk, Murat Türk, and obviously Martin Metz. And the objective of this talk will be directly addressed next to our friends who are registered in the webinar 202, and those are involved in 58 countries. And I hope you enjoy this webinar today with light in Spain. The three lectures that will be done by such very well-known speakers are addressed to the endotype, meaning that in the first, Murat will talk about pathomechanisms, such pathomechanisms that really are the cause of the endotype will be expressed in the clinical, some clinical behavior that will be expressed or really addressed and explained by Emek. Obviously, we learn a lot of endotype coming from the treatments that we have, and such treatments reflect probably the endotypes that will be described, and probably even more in the next future. Then this course or this webinar is accredited by the UMS. Please address your questions, because at the end we will have questions and my colleagues will help me to address them and I correctly answer to you. Obviously, at the end there is a survey, but please take your time on do it, and then we can even do in the future best webinars. Then just to stay connected, and obviously to all the tools or all the systems that we have inside the UCARE network, and then we will then start with this webinar. But do not forget that we have another commitment in June 19, where mostly cold urticaria will be addressed also by experts, colleagues from our UCARE centers. Then register here, and just to continue next. It will be addressed later by Murat, but what's an endotype? An endotype is a pathophysiological term, and not necessarily this pathophysiological term define the characteristics, lesions of the disease. Then the phenotypes is the expression of the disease by itself. The endotype is the pathomechanism which is involved, and sometimes different pathogenic mechanisms are imprint in the phenotype. Then, with no more words from my side, I will like to introduce again for 3 times that I've done today, next, to the first speaker, who is Murat Türk, a very, very well-known speaker that will be addressed this first lecture for you all. Murat?
Hi. Okay, thank you. Hello everyone, again, it's really a great pleasure for me to be here with you today with this UCARE LevelUp webinar. So I'm Murat Türk from Kayseri, Turkey, and my topic will be pathomechanisms underlying endotypes. So we all know that chronic urticaria is a quite common disease with around 1 to 2% prevalence in all around the world. And we have 2 main subtypes with chronic spontaneous urticaria without any known triggers or causes, and inducible urticarias. We also know that these subtypes might have some other subtypes like cold-induced dermographism, like other forms of cholinergic urticaria, that follicular cholinergic urticaria, or food-exacerbated symptomatic dermographism. But currently, they are not well known, well studied. So our current international guideline does not cover them. So this is our main classification today. So before starting, thanks to Anna, she briefly described what is a phenotype, what is an endotype. A phenotype is defined as briefly as observable clinical characteristics with no direct relation to a disease process. So maybe briefly we can define a phenotype like female urticaria patients is a phenotype, but it gives us nothing about the underlying pathophysiological mechanisms. And also a person's phenotype may change over time. These definitions like phenotype and endotype are really quite popular these days in the allergy world, like especially in atopic dermatitis and asthma. There are well-known phenotypes and also well-known endotypes. So in terms of chronic spontaneous urticaria, are there any observable clinical features that we can use as phenotypes? Yes, there are some like isolated urticaria, isolated mast cell-mediated angioedema, and urticaria plus angioedema are our main well-known phenotypes of chronic spontaneous urticaria. When we talk about endotype, so what is an endotype? This is a subtype of the disease condition, and it is defined by a distinct pathophysiological mechanism. Most endotypes really share etiological and pathogenetic pathways with nonlinear dynamic interactions that may or may not be present in all patients. What does this mean? Endotypes frequently overlap. Endotypes give us the clues about the pathophysiological mechanisms. So how can endotypes help us? They offer us the potential to enhance personalized medicine. We are in the era of biologicals. There are many clinical trials ongoing, and we are expecting more. So with these endotypical classifications, we can personalize our medicine. We can arrange our clinical algorithms based on these endotypical classifications and customize our treatments for each patient. So for a brief example, what we did in the asthma phenotypes, it came from big registries, thousands of patient data analyzed, and we know there is a benign asthma, severe asthma, early onset asthma, late onset asthma, obese asthma, and more. There are many other asthma phenotypes. But at the end, we have two basic endotypes in terms of asthma, in terms of these different clusters of these different phenotypical classification. We only have two main endotypes in asthma, with type 2 high and type 2 low. Type 2 high, this is the one we love because there are a lot of biologics in this section. Type 2 low is the quite gray area. We mostly don't know what's going on there. These are the examples of endotypes and phenotypes from asthma. So when we talk about chronic spontaneous urticaria, we said that we have three main phenotypes. Isolated urticaria, which complements the most of our patients. Nearly half of our patients have isolated urticaria. From the rest, most of them has urticaria and angioedema at the same time. And there's a tiny group, which is the mast cell-mediated isolated angioedema. And what endotypes do we have in chronic urticaria? We have four main endotypes, actually. The first one, type 1 autoallergic endotype. The second, type 2B autoimmune endotype. The third, their combination, type 1 and type 2B at the same time. And the fourth one is the most gray zone, most unknown part, the one with unknown mechanisms. So if we ask, are our endotypes or phenotypes reflect our endotypes? Unfortunately not. A patient with isolated urticaria might have any of these endotypes. A patient with isolated angioedema might have type 1 autoallergic, type 2B autoimmune, a combination of none of them. So this is the problem in urticaria. In asthma, it was possible to make this classification, make this connection between phenotypes and endocrines, at least partially. But in our phenotypical and endotypical description does not allow us to make this connection together with these phenotypes to the endotypes. This is a quite recent paper that I like very much. So they classified our endotypes, like I said before, type 1, type 2B, their concomitant combination, and the one without any type 1 and type 2B clinical features, and which is a quite big population of our patients, around 40% of our patients. It's not possible for us to send any direct or indirect relation of this type 1 or type 2B endotypical features. Most of our patients with type 2B also have type 1 endotype. Some of our type 1 endotypical type 1 autoallergic ones, some of them has also type 2B at the same time. And we have also this concomitant type 1 and type 2B group. They have different typical patient profiles. difficult response to therapy, different identification, different biomarker profiles which we define, which we'll talk about today. Also, we also proposed this underlying mechanism recently in a recent paper. Maybe in the near future, this classical type 1, type 2b endotypical classification won't let us to better define or better characterize our endotypical classification. Maybe we might rearrange this classification into Fc epsilon dominant and Fc epsilon non-dominant mechanisms. So when we talk about this Fc epsilon non-dominant mechanism, X2 is quite popular these days, which I will show some slides about it later. So how can we degranulate a mast cell? There are a lot of pathways, a lot of receptors that can degranulate a mast cell. It's not only Fc epsilon. You can degranulate a mast cell through interleukin 4, interleukin 5 receptor, through interleukin alarmin receptor 25, 23. You can degranulate a mast cell through coagulation, through complement receptors, through PAR receptors, KIT receptors, X2. You can degranulate a mast cell with cell-to-cell interactions. So we don't have any single receptor that can degranulate mast cell, because it's sometimes confusing if this type 1 or type 2b or Fc epsilon is our only pathway that can degranulate mast cells. So omalizumab should have been worked in all patients with 100% response rate. So there are some unknown combinations of these different receptors. Some of them are activators, some of them are inhibitors on mast cells. So we know if we are talking about chronic spontaneous urticaria, we need to see the mast cell degranulation. But mast cells are not the only cell that we see in the pathogenesis of urticaria. All kinds of cells are in this microcirculation. Eosinophils are there, basophils are there, different kinds of T helper cells are there. Complement system is active, coagulation system is active. Also, nerve cells make some direct or indirect interaction with these mast cells. So it's a quite complex microenvironment that we have in chronic urticaria. If we look closer to the pathogenesis or to pathology of urticaria, we see a mixed cellular infiltration. As I said before, eosinophils are there. In some cases, basophils are there. Mostly the T helper 2 type, but all kinds of lymphocytes are there. We see eosinophenia, we see basophenia in some of our patients. So mast cells are really crazy cells of our body that can kill us in minutes or in seconds. They have a lot of activator receptors, and also they have a lot of inhibitory receptors on them. So in urticaria, we know that there's some increased mast cell activation receptor stimulation. Also, some of these receptors are upregulated and increased on cell surface. Also, in some cases, there is an intracellular signal defect that causes mast cell degradation, like CAK and SHIP1 phosphate pathways. So as we started our endotypes, we said there is a type 1, type 2b. What is type 10 autoimmunity or autoallergic endotype? It is a classical type 1 hypersensitivity reactions, but this time we produce IgE against our self-antigens, in which there's more than 200 autoantigens defined in this disease. Some of them are quite popular, as we know, that IgE against TPO, interleukin 4, 24, eosinophil peroxidase, eosinophil cationic protein, and more. The problem in here is they are not specific to this disease. We cannot diagnose our patients only with these biomarkers. It's not specific to chronic spontaneous urticaria. For an example, IgE against dsDNA is also a good marker in lupus patients with this renal involvement, an example. Also, a recent paper also showed that 1 in 5 patients with CSU also might have IgE against tissue transglutaminase. The problem in here is we don't know whether they are functional or not. Okay, there are a lot of autoantigens there, but we don't know are they functional or not. So, in the clinical practice, how can we show type 1 autoimmunity? In vitro, it's not quite easy because no commercially available marker exists. All of them are shown in previous studies. Total IgE level is also a problem, like especially in countries like in Turkey or in India, because we have a lot of patients with parasitic infections. So increased level of total IgE, unfortunately, does not help us to discriminate between type 1 and type 1 or type 2b, but low levels of total IgE might have. But what is the best way to clinically show if a patient has type 1 or type 2b endotype? If a patient has a very fast response to anti-IgE treatment and to omalizumab, it is a quite high probability that this patient might have type 1 autoimmunity. There are some markers mostly are used mostly in type 2b autoimmunity, which I will describe later. When we talk about type 2b autoimmunity, it's quite different. This time we have IgG against Fc epsilon receptor or the IgE itself. But also there are IgM, IgA against Fc epsilon. We know that, but we again don't know are they functional at all? Because they are not all of them cause histamine release, and they can be also shown in other diseases like IgE anti-dsDNA in lupus. In this case, they are also shown in other diseases like severe asthma. Some of the patients severe asthma might have IgG against Fc epsilon, or some healthy people also have this IgG levels. So again, it's not possible to diagnose chronic spontaneous urticaria with these markers, at least. This is a quite highly ranked, highly cited paper. We all know, thank God, these patients are not quite high proportion. The ones with only type 2b phenotypes are the quite lower proportion of our, patients, like 8% of the patients with chronic spontaneous urticaria has only autoimmune endotype. These are the ones with more severe disease. These are the ones with low IgE levels, and these are the ones with high IgG anti-TPO levels. So how can we show type 2b autoimmunity in our clinical practice? In vitro, we have AST and basophil tests like basophil activation test, basophil histamine release assays, and as I said before, IgG against TPO or IgG against Fc epsilon itself. Again, total IgG is quite confusing. Higher numbers, I said before, increased numbers of total IgG mostly does not rule out or show us the way to the underlying endotype. But in here, low numbers of total IgG is really quite helpful, especially if a patient has a total IgG level less than 10 units per milliliters. It's quite high probability that this patient has a type 2b endotype, and also it's quite probable that this patient might not have a clinical control with omalizumab itself. Unfortunately, there are high specific biomarkers, IgGs, immunoglobulins, but again, they are not commercially available. We cannot use them in our clinical practice. This is another problem with the CSU. We don't have a specific biomarker that can reflect the treatment response or the disease severity. We have to rely on subjective patient-reported measures in this disease. Is it possible to have the type 1 and type 2b at the same time? Yes, it's possible. Most of our patients with autoimmune urticaria also have autoallergic urticaria, but it's not the same in the opposite way. Some of the patients with autoallergic urticaria has autoimmune endotype as well. Again, we have type 1 with high numbers of IgE, with rapid response to anti-IgE treatments. We have type 2b, they mostly have positive basophil test, and they are unfortunately generally have poor response to anti-IgE treatments. This is the gray zone. This is the zone that we don't know, and this is nearly the half of our patients. It compromises the half of our patients. So how is it possible that the mast cell degranulate without Fc epsilon mediated mechanism? As I said before, neuroinflammation is quite popular these days. I like this phenomenon very much, and X2 is our popular receptor these days. Not only in chronic urticaria, also in drug allergy, it's quite popular these days, because we know there is a mast cell and nerve cell interaction in this disease. The mast cell release nerve growth factor, say the nerve cells come together, we will work together in this disease, and nerve cell release some neuromediators which may degranulate mast cells or decrease its degranulation threshold. Previous studies showed that in patients with chronic spontaneous urticaria, their serum levels of these neuromediators are increased in chronic spontaneous urticaria. How can we stimulate the X2 receptor? It's another crazy receptor. Actually, it has quite popular, quite spectrum of different ligands, starting from some cellular interleukins, different from cellular interleukins, cellular products, and also some exogenous drugs also can stimulate X2, like quinolones, opiates, local anesthetics, icatibant also may stimulate X2 receptor. So it's also a different and interesting paper. So Fc epsilon we know can degranulate mast cells, X2 also degranulate mast cells, but if we combine them, they have a additional effect. You can see anti-IgE mediated mast cell degranulation, compound 4880 ligand used for the X2 activation, and they combine. Mast cells degranulate more if we use them both at the same time. So we talked about phenotypes, urticaria and angioedema. We'll talk about some markers, potential markers, IgE, total IgE, IgG, TPO, INA, CRP. So we need to do some cluster analysis if we have these kind of phenotypes or different patient characteristics. So what is a cluster analysis? Cluster analysis is a statistical method for processing data, especially big data. It can process thousands of parameters at the same time. It works by organizing items into groups or clusters based on how closely associated they are. It's done before in asthma, in atopic dermatitis, and we want to see whether is there any clusters of urticaria. We done that a couple of years ago with the help of our friends from Charité, and we found 4 different clusters. Cluster 1 was the CINDU. Cluster 2 seems to be autoallergic one. Cluster 3 seems to be autoimmune one, and the last one was the one with the high other concomitant diseases. So my last presentation, chronic urticaria, is a journey for our patients. We need to control their disease completely. So we need some tools to measure their disease control, disease activity on quality of life. So I recommend you all to use Cruise application. Thank you all for your attention.
Thank you, Murat. You can hear me?
Yeah, I can hear you, Anna.
Emek, going fast to your lecture because we are out of time.
Sorry about that.
No worries, Anna. My presentation is not that long because indeed we don't know too much. We don't know a lot of information about the clinical phenotypes, but I tried to gather some information about what kind of clinical endotypes. We called it clinical endotypes, but it's indeed, we should be calling it phenotypes, but I think we can also say it clinical endotypes. So thanks, Murat, for making the base for my presentation, and thanks, Anna, for this very nice introduction to the session. So it's my pleasure to start, and I'm skipping this for sure because we had 2. But why endotyping matters is because we will move beyond the clinical features, and maybe we learn more about the pathomechanism insights when we endotype the diseases, and then understand biological and immunological differences that may be lying because we already, as Murat also said, we already know very less about why chronic spontaneous urticaria occurs and mechanisms underlying. So we need, I think, from clinical observation, we can learn a lot about disease pathomechanisms. And then we can have personalized treatment, which Martin will be speaking about in 15 minutes. So as Murat already showed, we have the classification of urticaria for years, but do we think that all the chronic spontaneous urticaria patients, all the cold urticaria patients are the same? We know that they are not, because some are responding to treatment, some are not responding, some have angioedema, some do not have angioedema. So for sure, and some are children, some are elderly. And we know that for sure they have different characteristics. This study is a very nice summary of what we have currently as molecular endotypes of CSU, as Murat already mentioned. So we can have some biomarkers such as total IgE, and we can maybe estimate if a patient is type 2B or type 1 CSU, but currently we are not standing there. Maybe also we can think about treating the patients with some different treatments when we know the endotypes of these patients. So let's dive in different endotypes, clinical endotypes. For example, pediatric versus adult CSU. Do they really differ? For this, we did a analysis from our patients with pediatric allergy immunology unit, and we compared the adult and children CSU patients. Then we saw that pediatric patients had a lower female dominancy, they had a shorter disease duration, they had lower rates of angioedema, and also they had less IgG anti-TPO positivity, they had less CRP positivity, less eosinopenia, and also less autoimmune thyroiditis. So we thought that maybe, and they didn't show a very refractory disease. They were responding very much better to antihistamines, and they required less omalizumab treatment when compared to adult patients. And interestingly, this difference was starting at the age of 12. So after age 12, the patients, the CSU patients, pediatric CSU patients start to behave as adult CSU patients. So maybe we thought, do children have more type 1 endotype? As Marcus was always mentioning, maybe first comes the type 1 autoallergic urticaria, then it may be replaced by IgG type autoantibodies, then we are having a more refractory and type 2B CSU, maybe more in the adult patients. So we also compared patients with CSU patients with inducible urticaria and also isolated inducible urticaria. And we saw that when there is associated CSU, then there is more angioedema, there are more emergency referrals, need for systemic steroids, the disease control is lower, and there are more comorbid systemic disorders when inducible urticarias are accompanied by CSU. And isolated CSU CIndU patients were younger in our cohort. So then we thought that CSU plus CIndU patients have a more severe and refractory disease endotype than CIndU, isolated CIndU patients. So when CIndU is associated with CSU, then it apparently behaves like CSU rather than inducible urticaria. So we also compared patients, female patients with male patients, and we also found some differences that female CSU patients are suffering more than male CSU patients. What we found in the study, we analyzed the CURE registry data, and then we found that female CSU patients are a bit older than male patients, and they had more VIL plus angioedema presentation compared to males. They had more family history of CSU, and they had more systemic symptoms. They had more quality of life impairment, they had less controlled urticaria, and they had more sleep disturbance. And also when we checked the comorbidities, female patients had more asthma, they had more thyroid disease, more autoimmune disease, more gastrointestinal disease, and more depression. And also, we saw that female patients were responding less to all CSU treatments, to antihistamines, to high dose and standard dose antihistamines, to omalizumab, and to even cyclosporin treatment. So we thought that females have more refractory disease, maybe even more, they are having more type 2B autoimmune CSU compared to male patients. However, of course, we do not have a comparison of IgG autoantibodies. There is only one study that showed that female patients had more ASST positivity, but we don't have any information about antibody occurrence compared with females and males. Maybe we can learn it from the CU tiger study. I'm curious about it. And we also wanted to learn if there are any ethnical or geographical differences in CSU presentation. Then we did an analysis from the COVAX-CU data, and we analyzed the most common ethnical populations, and we saw that, interestingly, Asians had less female dominancy. You know, we always find 75% female dominancy in our populations, but you see here Asians have a less than 60% female dominancy, and the BMI was apparently very low in Asian patients. BMI over 30 was found very less in the Asian population. However, Middle Eastern population had the highest BMI. And also, disease duration was shorter in Asian patients. In the accompanied inducible urticaria was very less in the Asian population. However, it was really high in the Latino Hispanic population. And associated angioedema was apparently very less in the Asian population. 33% of the patients had angioedema plus wheals, compared to around 60-70% in the other ethnical populations. So yes, then we thought that maybe Asians have they have a milder disease phenotype, or maybe they are having more because they also had more atopy. So maybe they are having more type 1 autoimmune CSU, but of course, this is just a hypothesis. And also angioedema versus non-angioedema. Some patients have both wheals and angioedema, while some patients have only wheals. And when we compared patients with angioedema without angioedema, we saw that when there is angioedema accompanying wheals, the disease duration is longer, disease severity is higher, and antihistamine resistance is higher, and the overall remission rates was lower when there is associated angioedema. And we also checked the laboratory findings of our patients, and we saw that increased CRP levels are higher and ASST positivity are higher when there is angioedema accompanying wheals, while skin prick test positivity was higher when there is no angioedema but only wheals. So we can also make some assumptions. Maybe when there is angioedema, then maybe it's a sign of type 2B autoimmune urticaria, which has been mentioned in previous studies. So there is also another cluster analysis. Murat already mentioned their cluster analysis, and it's really interesting. So I didn't want to take that study to here, but there is also another cluster analysis that analyzes the remission and relapse patterns of chronic urticaria patients. And then they came out with 4 clusters where cluster 1 is having a early remission and long remission, where cluster 2, they have a delayed remission and short remission, when cluster 3 and 4, they have both a delayed remission but a short remission. And they concluded that cluster 4 had the most frequent chronic urticaria diagnosis and treatments and highest comorbidity burden, polypharmacy, and resource usage. So I think we are learning a lot of information from these analyses, comparing the clinical phenotypes of our patients. And then I think we will be learning more about the underlying mechanisms. And yes, with talking to each other, discussing and making presentations, I think we are learning a lot about chronic spontaneous urticaria. And thank you for your attention. And I am giving this stage to Martin. Looking forward to hear his talk.
Thank you. Anna, do you want, because there is one question, should we ask this question to Emek first, or
At the end, Martin.
At the end. All right.
At the end,
then,
we can discuss. Okay.
Yeah. Then I will start with my presentation. And I got the nice title of Precision Medicine According to Endotypes. I mean, this is, of course, exciting if you have the possibilities. So what I will try to do is, see if we do have these possibilities yet. And to do so, we have to look at our current treatment options. And this is actually more than the current treatment options. It's the options that we will have soon, most of us, because it's the new treatment algorithm that was consented on in the guideline conference December last year. So this is not yet published. So please be aware that the wording might be different once it comes out, and there may be country-specific differences. But what has been consented and what will be is this new step 2, where we now start to have options. So it's not only omalizumab, but there's also dupilumab, which is now approved in 4 countries. It received last week, 8 days ago or something like that, approval by the FDA. And then there will be, most likely in the future, remibrutinib. So this should offer us possibly precision medicine. And let's try to look at the possibilities. What are our current options regarding precision medicine with the drugs that are or will be in the treatment algorithm of the guidelines? I left out antihistamines because this is not really precision medicine. It's downstream of mast cell activation. It's histamine, and it works or it doesn't work in any of our patients. So it's about OMA, DUPI, and REMI. And I will go through each of these drugs and see what we have. Looking at the phase 3 trials, Asteria 1, 2, and Glacial, I mean, of course, we see efficacy, but we don't see anything else. But this, because this was for all comers, regardless of what the endotype or even phenotype of these patients are. Nevertheless, we, of course, do have some information that might guide us in the future. And this is, for example, the individual time to respond in patients treated with omalizumab. So you see individual patients for every line, and 1 week of treatment is 1 bullet point here, and deep red is high UAS 7 score. And this was from one of the phase 2 trials, and only those patients treated with omalizumab. And what we can clearly see is that there are non-responders. I mean, we know that, and we knew that from the phase 3 trials. About 1/3 are non-responders. And if we only look at the responders, we also see a differential response. So 1/2 of those that respond to omalizumab require a long time, up to 6 months, to show a treatment response, and about 1/2, so 1/3 overall, that show a very fast response already after the first injection. And we do have some information on who these patients are that take longer. So this is from real-world data, looking at patients that we have treated way back, and only looking at responders. So that this does not include the non-responders. And we see this distinction between the fast responders and the slow responders. And the distinction is between the BAT positivity, so basophil activation test. And we can assume that within this basophil activation test positive patients, we have mostly the type 2B autoimmune patient, even though based on what Murat said, there might just as well be overlapping patients in there. But those patients that are BAT positive clearly take longer for OMA to respond. But it's not only that. So Anna and her group and we around the same time showed that it's not only the late responders, but also the non-responders that do show these features of type 2B autoimmunity. So if you only look at the non-responders, here in Anna's group, it was 100% of those that were ASST positive, and the vast majority had very low total IgE levels, as you heard before from Murat, indicators of type 2B autoimmune response. This is what we also looked at, the total IgE levels, and you see that among those that did not respond at all, there's the highest rate of normal or high IgE levels. So the problem you also see here is that it's not exclusive. So you do have patients with low or very low total IgE levels that do respond, and we also have patients with elevated IgE that do not show any response at all. Coming closer to a positive predictor, so to make really precision medicine possible would be, if we identify, okay, you are going to be a super good responder. And interestingly, the best that we have is possibly the oldest, and this was in the Exquisite trial, where patients were selected for the presence of auto-IgE, so auto-IgE against TPO. And in those that were really pre-selected for these auto-IgEs, there was 70% that showed a complete response, no more signs and symptoms of the disease versus 4.5. Now, this is where we are at the moment with omalizumab. So we can say that, yeah, okay, it's best suited apparently for patients with presence of auto-IgE. It may not be optimal for patients with markers of type 2B autoimmunity, even though this is not exclusive. So my conclusion on this is we don't yet have a definite marker. We have some indicators, but there needs to be further research. It seems to be better suited for normal elevated IgE, and not so much for those with low IgE and other features of type 2B autoimmunity. Dupilumab, phase 3 studies. Here, the phase 3 studies already differentiated between OMA-naive patients and OMA-experienced patients, which means in the end, incomplete responders to omalizumab. And I mean, basically, what we see here is that it may work in both of these patients with some little difference in the response. It overall takes a long time, but this is same true for both of these patient subtypes. And that's really at the moment what we have as a possibility to select. So what are our options regarding precision medicine? Well, I don't think that we have this yet for dupilumab. It's possible from the phase 3 data for all of the CSU patients. What we might be able to say is that it may not be optimal for patients who require fast onset of response, but this is certainly not a clear endotype. So again, the conclusion is no definite marker available yet. We can see that regardless of endotype, there might be a benefit for choosing patients that have type 2B comorbidities that lie within the indication spectrum of dupilumab. We don't know yet who are the absolute non-responders. So that finally brings me to remibrutinib, and we have the phase 3 data here, I just show Remix 1, one of the phase 3, but it's the same for Remix 2, the identical other phase 3 trial. And again, here we are looking at all comers, so patients that responded to OMA and did not respond to OMA, regardless of whether they have a type 1 or a type 2b background. And we see a very fast onset of response within a few weeks and an overall excellent response over time. But here again, we do have also the information on these OMA experienced patients, so mainly non-responders. But it's not a distinguisher for who we should choose, because it works in both. It works in those that did not respond to OMA adequately and those that are OMA naive. So telling us it probably shows similar efficacy in both type 1 and type 2b autoimmune patients. So again, regarding precision medicine, well, not too much information at the moment, I'm afraid. Possible for all CSU patients. Again, not an endotype, but we have this fast response, fast onset of action in those that do respond. So if we require that, then this might be the drug to go to. So again, my unfortunate conclusion, no definite marker available yet. Regardless of precision medicine, the benefit is, it's different. If you call it an endotype, that a patient doesn't like needles, then this would be one. So my conclusion, it still holds true what I said in the beginning. Having novel treatment options offer possibilities for precision medicine, for sure. They have different mode of actions, and therefore there is the chance of selecting based on maybe also features that we do not know yet. So we are on the way to make precision medicine possible in the treatment of CSU, but I don't think, or we are definitely not there yet. So my final conclusion is that we have large areas in need for research. And this is something that many of you and also we are looking into. We still have to identify biomarkers that clearly predict treatment response. I mean, we have some that guide us, and total IgE is at the moment, I think, the best as we had, and as Murat also mentioned before. But there is the need for better ones that clearly predict treatment response and not only predict unlikelihood of a treatment response. And to really be able to use this then it's absolutely crucial that we develop and validate assays to detect these biomarkers fast and reliable. And at the last GAF, you heard a presentation by Jorge Sanchez that they are in the process also of developing an anti-IgE assay. Something like that would be good. So I see as best candidates like bedside tests for the detection of auto-IgE, and ideally not only IgE anti-TPO, but general auto-IgE, but also for auto-IgG, and maybe then even combine them to get a better predictor, have this as a lateral flow assay, for example, something like that. But it would also be good, as Murat mentioned, look into the X2 agonists. Maybe we can also, in the future, define then non-responders to what we have and potentially responders to future X2 antagonists. Yeah. And with that, and I think for all of us, I'd like to thank you for your attention and happy to discuss everything.
Thank you, Martin. Thank you, Emek. Thank you, Murat. Then we can start a discussion during 10 minutes. Emek, maybe you can address the questions again, and Martin and Murat can answer you.
Yes, so Ankur was asking if angioedema is a factor that defines acute urticaria progression to chronic urticaria. There are some studies that shows higher disease activity or autoimmune features are predicting progression to acute urticaria from chronic urticaria from acute urticaria, but I am not aware of any studies showing that angioedema is a predictive factor for chronification. So my answer is I don't know. We don't have this study showing it.
And if I can add to that, I mean, I fully agree with everything that Emek said. However, we did a small study with 300 plus patients with acute urticaria, and looking at the trying to find markers that predict who's going to become a chronic urticaria patient and who's not. The number is not high enough to really draw final conclusion, because, as you know, not too many get to be chronic, and there will be a UCARE project looking at this, and hopefully many of you will join us in that. But what we did see, actually, that there's a lower rate of angioedema in those patients that stay to be acute urticaria patients. But that might just be because there's a shorter time period, for in acute urticaria to also have angioedema. And but what I would say that it's at least not a predictive factor of these patients becoming chronic spontaneous urticaria.
Emek, the difference that you found between females and males, or children and adults on ethicals, because you're angioedema or not angioedema, because you always said we speculate, maybe you speculate because you found differences. Those differences you found, they are due to different endotypes. Do you think that we are really different endotypes according with the comparisons that you did?
I'm speculating it. Of course, I do not have any evidence, because I think we have to look for all the autoimmunity factors, including the autoantibodies, and also in the purist study, to say that it's type 2B autoimmune urticaria, they have to have all 4 factors: basophil activation test positivity, ASST positivity, the IgG type autoantibodies. So I think it's only speculation at the moment. So we need to really do a strict study to be sure about it.
Martin and Murat, because we defined it different endotypes, but you already showed that there are mixtures, and probably we don't have all the endotypes defined. That's true?
Yeah, that's correct.
Opinion, and Martin? Because you already did the differentiations, if you agree.
Yes.
So urticaria which are mediated by the high affinity Ig receptors, and the others which are not mediated by the Ig. Even you did a phenotype subdivision of urticaria, and angioedema, and just angioedema. What's your opinion on this? Because Martin and Murat.
Martin?
Yeah, I mean, we have all these things, and this is good. I mean, we have an excellent basis with the chronic urticaria registry, where we get all this information. What we don't yet have is the right tools to look at. So as I said, essays and so on to clearly define this. But once we have those, we can start looking at this all over again. And look at also these clinical phenotypes, whether they really correlate well with the endotype. I don't think they do, actually. So we hear a lot about it's the severity that is a little bit associated with type 2B autoimmunity, and along with that we get all these other associations that might just be by chance. So I don't think that these clinical phenotypes are true endotype differences, and but as I said, we have the possibility in the near future, with the power of our UCARE network, actually to address these questions.
That?
I totally agree with Martin. It's not possible to define any endotype with these clinical features, because no previous studies show that. But for an example, presence of angioedema might be a predictor of long disease duration, but it's not 100%. We cannot rely on this phenotypical feature. Also, we have a recent project that not published yet. We have immunohistochemistry stainings of patients with angioedema and without angioedema, and we found that Siglec-8 and X2 levels of the patients with angioedema is higher than the ones without angioedema, and conversely, ones with the angioedema had the lower CRTH, prostaglandin receptor expression on their mast cells when it compared to ones without angioedema. So some inhibitors is increased in some phenotype, some activators is increased in the other phenotype. So it's not atopic dermatitis, it's not asthma. Our patients are not very lucky at all. So our phenotypes currently does not give us any clue about the underlying phenotype.
There are patients that just suffer one chronic spontaneous urticaria episode along their life. And there are others that probably suffer 3 or 4 or 5 long episodes of chronic spontaneous urticaria along.
Intermittent ones, yeah.
No, intermittent, no. Chronic episodes, 3 years and after 5 years.
Long-term episodes, okay. Okay.
Years. Then do you think, because Emek mentioned that some way was thought that there was a change in the type of endotype of the mechanism that could be induced this common rash, because always the rash is the same, wheals and angioedema or not angioedema induced by some external or internal or physical behaviors, but the wheal is always the same. Do you think that could be really, Martin and Emek, a change in the endotype of the patients who suffer it, or we are patients who really are clustered of autoimmune diseases that suffer chronic spontaneous urticaria, and others who really never has had a cluster of autoimmune diseases associated? Do you think the concept of atopic march, I don't think it is applicable to the urticaria because we don't have different diseases involved. It's just urticaria. That's it. Could we discuss this?
Yeah, it's not easy to answer, I believe, but from my clinical perspective, instead of changing from one phenotype to other phenotype, like from urticaria to angioedema, I believe CIndU is a different type, and it adds itself on the way, on the journey. Sometimes patients start with only CSU or ST, and then on the journey, on the progress of the disease, the other one add on. So instead of phenotypical change, I believe subtypical change might be more prominent in this disease.
Martin, do you have any opinion on this?
Yeah, I agree in regard to CIndU, where I really do think that this rather seems to be separate, even though there's high rate of comorbidities. But regarding something like Marcus always called the urticarial march, I do think that this occurs in terms of a change in autoantibody profile over time. So, I mean, this is something that we also all want to look into. But my guess is that really, if we look at patients who have CSU for 20 years, that most of them will have IgG autoantibodies, and the same patients might not have had these in the first year of their CSU, so that this somehow develops over time.
Okay, we are in the last minute of this webinar.
Anna, there are actually a number of questions. I know that you don't see them.
Then, if you want, we can continue more than 1 minute. Then,
well, I don't know.
Maybe we can go over very quickly so that we answer these questions. What do you think?
Yeah. Okay. Let me start. What is the key differentiation between biological therapies based on patient profile or based on IgE levels or BAT? At the moment, the only thing would be based on IgE levels, but nothing else.
Yeah.
Next.
Emek, when patients presenting with long-lasting wheals but without vasculitis, which treatment may be more suitable for them?
Yeah. Yeah, long-lasting wheals and sometimes even wheals with ecchymosis can be a sign of eosinophils infiltrating the wheals. So maybe these patients need other treatments. For example, eosinophil or neutrophil, maybe. Yeah, we can think about dapsone or maybe hydroxychloroquine to help.
But only a second or third. I mean, after our
Yeah,
regular
of
treatment
course,
start.
of course, of
Yeah.
course. If they are refractory, then maybe we can, because there are not many studies that are showing the duration of individual wheels, effect of a duration of individual wheels on the treatment response. I'm not aware of these kind of studies. But long duration and ecchymotic wheels can be related to eosinophilic infiltration.
You stop me, Anna, if I just keep asking a question. Murat, addition of angioedema in patients with CSU may induce a different biological treatment election? Ivan is asking that. Would you?
Does it mean so it will change our indications?
Yeah. Would you base your treatment decision based on the presence or absence of angioedema?
No.
Me neither. No. All right.
CIndU as a coexisting urticaria in addition to chronic spontaneous urticaria. What do we know about the clinical endotype? So as I already mentioned in my presentation, when CSU plus CIndU, then it really behaves like CSU rather than behaving like a CIndU, and it becomes more refractory to treatment, angioedema, and longer disease duration. So phenotype. And also we found some differences between, for example, cold urticaria patients, cholinergic and symptomatic dermographism patients. We found lower IgE levels in cold urticaria patients and more anti-TPO positivity, but it's just our cohort, so we don't know so much information about these differences. I think it's a open.
The last time we conclude. Do you have any question?
Yeah. So which one to pick? If you ask me, there. Because there's a question for me. Maybe I.
Yeah. Sandil is asking directly to you.
Yeah. I have a case who has been refractory to OMA 8 doses, even with decreasing the period or for increasing the dose of OMA taken 3 doses of Dupi, still status quo and no improvement with cyclosporin. Given 4 milligram per kilogram body weight, we are reaching a roadblock. Yes, this really sounds like a roadblock. How to go about? Well, these are, I mean, we all have these patients. They're luckily not that many, but super complicated. I don't have an answer for this at the moment. What I can tell you is we had similar patients recently that we treated with anti-IL-23. And because we had it and we just thought that, hey, let's try. And actually all 3 then improved. It took a while, but those were just like these patients, refractory to everything, including cyclosporin. But we don't have a clinical trial showing this. I think these are the patients where we have to go into trial and error. Once we have, of course, a mast cell depleting drug, then this would be the best to go for these patients like barzolvolimab.
For sure.
Yeah.
Maybe we can conclude with, do you have any other stressing questions in your eyes, Martin?
So there are 15 questions there. Murat, Emek, would you pick one of them here?
Some of them are similar.
Use the IgG, anti-TPO total IgE index in clinical practice to help. Yes, it's from Pavel's study. They found that when it's over 2.88, then it can be an indicator of autoimmune type 2B urticaria. But I also tried it in my patients. It was 1,000 patients, but I really couldn't find a difference. So I
Not
think
very specific
studies to say that it's a real biomarker. So you can check, but
it's not an excellent biomarker.
Is an excellent, you said?
It's not an excellent. It is one, but it's far from
being the only excellent one that we can achieve, but not the excellent one.
But it's definitely not where we want to be. We need better, higher sensitivity, higher specificity.
If BTK inhibitors do eventually show a preferential benefit in autoimmune CSU over autoallergic CSU, why do you think that is occurring? Maybe for you, Martin.
Yes, I mean, it's not higher, it's really the same. And the reason is very simple, because BTK is downstream of the Fc epsilon R1 receptor, and this is engaged in both type 1 and type 2b, at least in those type 2b, as Murat explained, where you have IgG autoantibodies that are directed against Fc epsilon or against IgE. Then it also goes through the Fc epsilon R1 receptor and therefore also through BTK. And that's why Remy works in both type 1 and type 2b.
Good. Let's conclude. Maybe we could have a common work to do together. And it's very simple. It will be to define really the phenotypes of CSU, because you already discussed, he said, urticaria alone, urticaria and angioedema alone, Murat said at the beginning of his presentation, as a definition of the phenotypes. And already we discussed that the CIndU is a different phenotype.
Yeah.
Such with CSU and CIndU are those phenotypes that could probably express just one endotype. Then I think, with humildad, we say in Spanish, I think we need to define better our phenotypes.
Yes.
Or should we define CIndU as another entity, not an urticaria? Can we define it as a different entity?
It's not a different entity.
But it's a black box, you know. No type 1, no type 2b.
The common lesion is the wheel, the trigger is the... You see, in such basic things, we have a different point of view that maybe could be very interesting to discuss together in the UCARE network.
And that's the fascinating thing, right? We have still so many things to address and to research on and work together within UCARE to answer these questions.
Good. Thank you, Emek. You were brilliant. Martin, always you were brilliant and contundente, we say in Spanish, and it's clear in the things that we have to do. And Murat, you did a very good overview of the pathophysiology. Then thank you very much to you three guys. Thank you to Materia Prima, Isabella. If you want to, we can proceed with the last slide. Then please remember to complete the feedback form. Go ahead. Stay connected on social media. Go ahead. And please join us in the next webinar that will be addressed to all of you. Then thank you very much. Good afternoon, good evening. We have light in Spain today, and they will continue working. Okay. Bye-bye.
Thank you.
Bye-bye.
Bye-bye.